Good evening, everyone, and welcome to the webinar on the theme Empowering Patients, Empowering Progress. It gives me great pleasure to invite our program director, Dr. Rachana Chennamaneni, medical oncologist from Hyderabad, to give the opening remarks. Over to you, ma'am.
Good evening. I welcome everyone and I thank AstraZeneca for giving me this opportunity to chair this program, and also Kavina Creations for arranging the platform for the discussion on lung cancer. Let's empower our patients by discussing the progress in lung cancers and see what's happening and what we are going to do with the new data we have available. So to begin the session, I would like to invite my dear friend, Dr. Lakshmi Deepthi, consultant medical oncologist from Kakinada, to give us an overview of lung cancer. Deepthi, over to you.
Good evening, ma'am. Thank you, ma'am. I thank AstraZeneca team and also Kavina Creations for giving me this opportunity. In today's presentation, I would discuss lung cancer incidence, the staging, and basic pathological diagnosis, and also just a simple overview of the treatment of various stages. Next slide, please. So as we can see, according to the Globocan world data, lung cancer remains the second most common in its incidence, whereas among mortality, it's the first most common. Next slide, please. Whereas in the Indian data, lung cancer is the fourth most common incidence and also the fourth most common cause of cancer-related death. So as we can see that the incidence of lung cancer is high, as well as the mortality associated with lung cancer is also very high. Next slide, please. So the main reason for this is, as we can see in this graph, the patients who are diagnosed in very early stage lung cancer are very less percent. Only 13% to 17% are diagnosed at very early stage. And the stage in which the cancer is diagnosed determines the survival rates. Next slide, please. As I have mentioned, the survival rates decrease with the increasing stage of the cancer. So with only the 10% of patients survive in the stage 4 lung cancer. That is, the 5-year survival is very less. Hence the high mortality in the lung cancer patients. Next slide, please. The main risk factors for lung cancer commonly seen are smoking, radon gas, family history, and exposure to any kind of radiation. So among the smoking, both the direct primary smoking and also the second-hand smoking also increases the risk of lung cancer, and the smoking is the most common cause. Next slide, please. The stepwise approach of diagnosis remains the same as other cancers. Once a patient presents to us the clinical history and by the imaging, we have to diagnose. If any imaging is suspicious of any lung mass, then we go for the pathological diagnosis and further the staging. Next slide, please. The most common imaging tests which are used to look for the tumors are the chest X-ray, which is the first primary investigation, followed by CT scan or either PET CT scan. The additional investigations which are used are the MRI or bone scan. The imaging helps us to determine the location of the tumor and also assess the lymph nodal involvement. Next slide, please. So for the tissue diagnosis, the most common method which is used is a tissue biopsy, which is the primary modality. Liquid biopsy is done only in cases where the tumor is not accessible or very small suspicious tumors. But usually liquid biopsy is not much helpful in the initial diagnosis. This is only as a supplementary method for the genetic analysis. The tissue biopsy can either be done by the bronchoscopic or also the CT guided biopsy. And even for the lymph nodal involvement, usually the transesophageal endoscopic ultrasound techniques are also used. Next slide, please. Coming to the staging, lung cancer is usually diagnosed mainly by the clinical staging because majority of patients are diagnosed at advanced stage and the surgery is not possible. Some patients of early lung cancer are diagnosed by the pathological staging. Pathological staging helps us to know the number of lymph nodes involvement and also to guide the further adjuvant therapies, whereas the majority are by clinical staging. Next slide, please. Coming to the staging use, the standard staging system which is used is the TNM according to the AJCC 8 classification. And I'm not going into detail of the TNM staging. Next slide, please. Coming to the end staging, the nodal involvement is divided into N1, N2, and N3. N1 is the ipsilateral pulmonary or hilar nodes. N2 is the ipsilateral mediastinal and subcarinal nodes. N3 is the contralateral mediastinal or hilar, and also supraclavicular nodes also comes under the N3. Next slide, please. The M metastatic stage is divided into M1A, B, and C. 1A is malignant pleural or pericardial effusion, and also separate tumor in the contralateral lobe. 1B is any single extrathoracic mets, or 1C is multiple extrathoracic mets. Based on the tumor, nodal, and metastatic stagings, we decide the staging. Next slide, please. So mainly the histological classification of lung cancer is grossly into two types, whether it is small cell or non-small cell. Again, the small cell are divided into the squamous or non-squamous. The most common among these is the non-small cell, and among that, adenocarcinoma is the most common. Other than squamous and adeno, the other types are the large cell carcinoma or adenosquamous or sarcomatoid carcinoma. The primary classification is between small cell and non-small cell. Next slide, please. Coming to small cell lung cancer, it constitutes about 10 to 15% of the entire lung cancer cases, and it has the worst survivals. The overall survival of small cell lung cancer is usually less than 1 year, and the median survival is 7 to 11 months. Next slide, please. The main reason for this is there is no advancement in the treatment of small cell cancer since the last 30 years. Even there has been no advancement in either chemotherapy or immunotherapy. Though there has been new agents among immunotherapy, the survival improvement with these agents is very less. Next slide, please. Coming to the non-small cell lung cancer, they are divided into either adeno or squamous, and again they are further subdivided into based on the genetic mutation analysis which we have done, and based on that they are divided either into EGFR mutated or ALK mutated, ROS mutated, etc. Next slide, please. There has been various advances in the treatment of the non-small cell lung cancer. There has been improvement in the genetic targeted therapies, and also the improvement in the immunotherapy, which has very much increased the survivals. Next slide, please. Coming to management of any patient of lung cancer, this is to be decided in a multidisciplinary team as any other cancer. Whether the patient is eligible for surgery or it has to be radiation managed or chemotherapy managed, it has to be decided between the team. Next slide, please. Coming to the management, we have to initially decide the stage of the patient. If the patient is of stage 1 or 2 with the disease limited to one lung and not involving any mediastinal lymph nodes or distant sites, the primary management is usually surgery, followed by any adjuvant therapy based on this pathological stage. Coming to stage 3, when there is mediastinal lymph node involvement without any disease elsewhere, it is classified as stage 3 disease. And in these three stages, the main goal is the cure. Next slide, please. So among the surgeries, the standard surgery which is done is the lobectomy. Pneumonectomy is usually done when there is hilar or any proximal tumors present in the larger airway tracts. The wedge resection and segmentectomy are only done in those patients who have very limited pulmonary reserve. Next slide, please. Coming to the outcomes, it has been seen that even the early stage lung cancer, even with surgery and chemotherapy, the 5-year recurrence rates are very high. That is around 50%. So hence the survivals are less. It has been seen that when the patient has been treated with adjuvant cisplatin-based chemotherapy in the LACE meta-analysis, it has been shown that there is increase in the 5-year overall survival benefit. But even with the adjuvant therapy, the survival rates are still less. Next slide, please. Coming to the unresectable locally advanced NSCLC, that is the stage 3 malignancy, stage 3 lung cancer. In this, based on the mediastinal lymph nodes involvement, it is classified either into 3A, 3B, or 3C. In this, the primary management remains concurrent chemoradiation along with sequential or concurrent chemo. Next slide, please. So, as I mentioned, the definitive chemoradiation is a standard of care. In some patients, we go for either sequential chemoradiation, or in some patients, it is concurrent chemoradiation based on the volume of the disease. Next slide, please. Coming to the metastatic NSCLC, this constitutes the majority of the newly diagnosed lung cancer patients. Around 57% patients are diagnosed in the stage 4. In this group of patients, the main goal remains is to extend the survival and also to improve the quality of life and also to decrease the debilitating symptoms related to the lung cancer. Next slide, please. So the available treatments in the advanced stages are it's either chemotherapy or targeted therapy based on the genetic mutations, or it's the checkpoint inhibitors. Usually with chemotherapy, the overall survival with chemotherapy alone was seen about 8 to 12 months. With the invent of targeted therapy, in the FLORA trial, it was seen that the overall survival was around 38 months. And whereas with the checkpoint inhibitors, there has been further increase in the overall survival, that is around 30 months. Next slide, please. So what is targeted therapy? This targeted cancer therapy helps to identify a particular cancer target, that is a genetic mutation which is present in the cancer cells, and it specifically inhibits that target and also kills that cell. So as it is very specific to the cancer cell, the side effects associated with this is also less. The molecular testing of the tumor tissue or the liquid biopsy helps us to know the molecular targets. And it has been seen that in lung cancer, around 50% patients have targetable mutations, thus which increases the survival. Next slide, please. Next, coming to immunotherapy. In immunotherapy, we target against the PD-1 or the PD-L1 markers which are present either on the tumor cell or our immune system, and which inhibits the immune-mediated signaling, thus increases the cancer cell death. So the various targets which are used in lung cancer are the either PD-1 inhibitors or the PD-L1 inhibitors or the CTLA-4 inhibitors. Next slide, please. To summarize, the 5-year overall survival in NSCLC is only between 10 to 15%. The main reason is due to the advanced stage in which they are diagnosed. Even though around 30 to 60% patients have undergone surgery, they eventually develop the metastatic disease. It has been seen that to increase the survivals in the early stage, adjuvant Osimertinib has played a major role to increase the survivals. Next slide, please. So the areas where the survivals in lung cancer can be increased are the main 4 areas. That is, we have to increase the lung cancer awareness so that more patients are diagnosed at early stage, and there should be increased access to the most innovative medicines, that is either targeted therapy or immunotherapy. And also we should have the increased survivorship, that is the cancer-related side effects and also follow-up pattern should be more present. And main to enable the early diagnosis, we should have increase the imaging techniques. Next slide, please. So to increase the patients diagnosed in the early stage of lung cancer, the main role is to be played by the general physicians. So the general physician should also be a partner in the management of lung cancer, because they should have the high index of suspicion of early lung cancer, and also prompt diagnosis should be done. And they should be aware that any mass could be lung cancer, and the referral to an oncologist or pulmonologist at the right time, and the availability of tests should be more. And also they also should have basic knowledge of the complications of the treatment and also to identify recurrences. So there is a major role of general physicians in also improving the survival of lung cancer. Next slide, please. Thank you.
Thank you, Dr. Deepthi, for finishing on time. And you have given an overview of lung cancer, starting from the epidemiology, the staging, surgical management, and you touched upon the targeted therapy and immunotherapy also. So any questions for any of the speaker, I would request you to please post your questions in the chat box. We can discuss them during the panel discussion. And moving on to the next topic, whenever we speak of targeted therapy, we mainly think of lung cancer because it has paved ways in various targeted therapies, and we have learned a lot in lung cancer management. So to give us more insights into the targets in metastatic NSCLC and how relevant is liquid and tissue biopsy in the present era, I would like to invite Dr. Kripa Bajaj, medical oncologist from American Cancer Center, Hyderabad. Dr. Kripa, please.
First of all, I would like to thank Dr. Rachana as well as Kavina Creations for this opportunity. Now I'm going to discuss regarding defining targets in metastatic NSCLC. How relevant is liquid and tissue biopsy in clinical practice? Next slide, please. Next slide. So we all know like NSCLC management is a poster boy for the target therapy. Apart from the CML, all the solid malignancies, lung cancer is the one which has more targets where we do test profoundly for looking for the target at every step of the progression. So what are the actual mutations we do come across? Most common is the EGFR sensitizing mutation, T790 mutation, exon 20, KRAS mutation, ALK fusion, HER2, MET exon 14 splice mutation, and ROS1 fusion, BRAF mutation, RET fusion, as well as NTRK mutation. So what are the emerging markers? The MET amplification and other driver mutations. So the past decade, there has been growing list of specific predictive markers for actionable genetic alteration, and that list will continue to grow in the future as well. And also we do see a plethora of drugs for lung cancer in future. Next slide. So this is the evolution of the lung cancer treatment. When people do say, when our teachers do say that lung cancer means they used to send to home when it got diagnosed, but now it got evolved quite a bit. Not just simple chemotherapy, a lot of mutations got detected. Not just mutation detection, we found the targets how to how to use manipulate the targets for the management of the lung cancer. So not just targeted therapy, but also the immunotherapy also plays a very major role. But now our discussion is mostly regarding the liquid biopsy and how relevant it is used in the metastatic lung cancer. Next slide. So NCCN guidelines recommend biomarker testing for all the eligible patients in NSCLC to help determine appropriate treatment options. So as per that, I previously discussed, if patient is having an oncogenic driver, so we have to, irrespective of the PD-L1 testing, we do act on the driver mutation only. And the emerging additional marker is a high-level MET amplification. So if patient is not having any driver mutation, then the PD-L1 comes to picture apart from the chemotherapy. Whether to use only immunotherapy or chemo plus immunotherapy, we do choose. All of us know this. Next slide. So in the resectable lung cancer also, the EGFR ALK holds good, the PD-L1 holds good, because we know like the adjuvant therapy is like upcoming, even the ALK target therapy is also upcoming. In the metastatic, no need to say the target therapy is very important. And tissue specimen versus plasma specimen, how to test? So most of the times we do try to take a tissue specimen, the preoperative biopsy or the surgical resection sample in the adjuvant setting, or diagnostic biopsy itself will be sufficient. So where do we use the liquid biopsy? Usually, but like right now, a lot of discussion is happening to send for the both solid as well as liquid, because cancer is heterogeneous, the cells may shed different cells, so that's why liquid biopsy is also equally important. Now the lot of evidence is coming to do both at the same time. But usually what we do practice, because it's expensive, we try to cut down the cost. If tissue is insufficient and unavailable, to consider complementary testing when patient is quite affordable. One second. And consider concurrent testing to minimize the test failure and to expect time to results. The third one, maybe in future, we may do both at the same time. Next slide. So overall survival in patients with advanced NSCLC in the testing group who receive biomarker-driven therapy as a first-line treatment versus those without. So it's significantly high. The outcome is significant. That's 18 months versus 6 months. Next slide. So there are multiple barriers to biomarker testing in clinical practice. The tissue biopsy sample collection. For suppose it's a bone lesion, we can't really do the tissue sampling. Though we do the tissue sampling, the processing is difficult. So tissue biopsy sampling is one where not feasible, or specimen quantity may be inadequate, or a lot of necrosis in the specimen. That's one common issue what we do see. Staging and diagnosis, the delayed and inaccurate staging and improper tissue specimen may occur. Ordering and biomarker testing, reporting. At every step, there can be multiple barriers. In the IASLC global survey on molecular testing in lung cancer, the main reason for failure to obtain a molecular diagnosis in Europe were insufficient tumor cells provided. Most of us also do across a similar kind of situation. The sample is inadequate, less than like 20% tumor cells. Like we do see a lot of reports likewise. Next slide. One important barrier to molecular testing is tissue availability. So the main stress or main importance of liquid biopsy is regarding the tissue unavailability. Our patient may not be really comfortable to do it. So tissue acquisition, 20% of the patients cannot undergo tissue biopsy. About 3% refuse to undergo tissue biopsy. The quantity and quality among patients who get a tissue biopsy About 7%, 20% cannot undergo molecular testing due to insufficient tissue or tumor cell content. The QNS in patient with NSCLC, if you see, the oral biopsy failure rate may go up to 43% as per this acquisition, quantity and quality. QNS in patients with NSCLC. So multiple levels, if you see, the failure go may high as 43%. Next slide. So what is liquid biopsy? It's a minimal invasive procedure that can be used to identify tumor-specific genomic alterations. For sure, liquid biopsy can't say this is adenocarcinoma or squamous cell carcinoma, but liquid biopsy is more helpful to detect the target only. So liquid biopsy consists of obtaining a circulating tumor DNA from plasma, which provides a source of clinically actionable molecular information. So deletions, insertions, point mutations, amplifications, translocations, and chromosome abnormality, everything can be detected easily. Next slide. So comparison of a major methodology for ctDNA analysis. So real-time PCR, digital PCR, NGS. So what are the variants detected? What are the limitations of detected? So if you look at the NGS is like the limitation detection is 0.01% to 5%. All the mutations present in analyzed gene regions. So what is the most recommended is NGS. RT-PCR, digital PCR, we used to do when only the snapshot of gene mutations. NGS is the best to cover broad profile, but when it's not possible, snapshot mutation. When really we can't afford, like most of our RBC patient, we do offer RT-PCR, EGFR, and ALK because these are the most common targets if possible. So yeah, next slide. Positive mutation results from liquid biopsy are therapeutic actionable metastatic NSCLC. In patients with metastatic NSCLC tested by liquid biopsy, assay in initial diagnosis. The sensitivity is 70% to 80%. A negative result requires confirmation with a tissue-based testing. The specificity is as high as 100% according to existing guidelines. In eligible patients, a positive driver gene mutation results alone from plasma testing is sufficient to select first-line treatment. Next slide. Multiple procedural methods are available for acquiring tumor specimens for biomarker testing in NSCLC. The bronchoscopy, for transthoracic, the CT-guided transthoracic percutaneous biopsy, thoracentesis, surgical, liquid biopsy. So liquid biopsy usually early stage, but metastatic, yes. So CAP, ISLC, AMP guidelines state that biomarker testing can be performed on tissue specimens obtained by any procedure. However, liquid biopsy is not currently validated in resectable NSCLC setting. This has to be addressed in adjuvant setting. No role of like doing this because like once the tumor specimen got removed, it may not shed. Maybe it's a really logical to think in that way. Next slide. Patients with resectable or metastatic NSCLC have distinct opportunities for biomarker testing. Opportunities for biomarker testing in NSCLC, an example of a patient journey. So diagnosis, staging, and treatment planning and treatment. So resectable, preoperative biopsy, opportunity for biomarker testing, plus or minus neoadjuvant therapy, surgical resection, opportunity for biomarker testing again. But for the metastatic, if possibility is there, yes, biopsy, otherwise liquid biopsy. Confirm biomarker status as soon as possible can help ensure optimal treatment decisions. Next slide. So the liquid biopsy testing is highly concurrent with the tissue-based testing for detecting guidelines recommended genomic alterations like all fusions, amplifications, mutations, everything can be detected easily. So overall concordance across all 4 genes was greater than 98.2% with positive predictive value of 100%. Next slide. So appropriate treatment choices for patients with metastatic NSCLC can be guided by tissue or liquid-based testing. In the cohort of treatment-naive patients with advanced NSCLC, there was no significant difference in PFS after EGFR TK treatment, regardless of liquid-based or tissue-based biomarker testing. So PFS in EGFR mutated patients with advanced NSCLC treated with EGFR TK as identified with liquid biopsy versus tissue biomarker testing, not much difference is there. The hazard ratio is 1.21, but still it's not significant. The p-value is only 0.42. Next slide. Liquid biopsy testing can improve turnaround time compared to tissue testing in metastatic NSCLC. Test turnaround time may be shorter for liquid biopsy testing. So a prospective test like with diagnose the turnaround time like almost like the liquid biopsy score really well. Next slide. Detection of patients with an actionable biomarker may be improved with integration of liquid biopsy testing. So what we do, like tissue first, liquid biopsy, but tissue plus liquid, there is a more, high high detection of mutation testing. So number of patients with metastatic NSCLC diagnosed and with NSCLC, when biomarker testing modality was used, tissue first, 60 patients identified with the tissue, and liquid first, 77 patients identified with ctDNA. So there is a step up of 28% with the liquid addition. But when both got combined, the marker detection stepped up to 48%. So concurrent liquid biopsy and tissue testing identified 89 patients with at least one biomarker, increasing detection success by 48% of patients eligible for appropriate targeted therapy. Next slide. The rationale for integrating liquid biopsy into routine management of metastatic NSCLC considers the challenges around tissue testing and diagnosis. So liquid biopsy may be useful in patients with difficulties undergoing a biopsy due to patient suboptimal clinical condition, unfavorable tumor sites causing difficulties in procuring adequate tissue. Liquid biopsy may overcome issues of scarce tumor tissue in the tumor biopsy. Liquid biopsy typically supports faster molecular analysis than tissue testing. Liquid biopsy may spare patients from additional invasive procedures. Next slide. Treating patients with target therapy based on positive results of liquid biopsy supported clinically. Change in target lesion diameter as determined by RECIST for patients with a therapeutically targetable mutation detected by liquid biopsy testing. It has they achieved complete or partial response of stable disease like with therapeutically targeted mutation. The detection is like very high. Next slide. Tissue and liquid biopsy testing have unique advantages and considerations. So liquid that is non-invasive, sufficient for testing if adequate quantity of blood is drawn, can overcome tumor heterogeneity. However, multiple factors can influence tumor DNA shedding. There's tumor size, location, vascularity. TAT is shorter. Liquid biopsy tests consistently show high completion rates. Next slide. Liquid biopsy can be integrated into clinical practice.
Dr. Kripa,
different.
Can we?
I think you finish. Yeah, I think sure.
Yeah.
Yes, ma'am.
Thank you.
Yes, ma'am. Sure. So it's always better to test tissue and liquid concurrently, though all of us are sending tissue first. If not, like in progression, we are sending liquid. But in future, maybe combining both may increase probability of detection of targets high. Next slide. Liquid was not at clinically validated for genetic testing resectable. So this we discussed briefly. So only at stage 4, the concurrence is like high. The positive concurrence is like just the concurrence is not so great. That's why resectable, no liquid biopsy, only metastatic we do. Next slide. So it's a complement or alternative to tissue biopsy, but negative plasma tests are non-informative and must be confirmed with tissue. Next slide. The algorithm, like clearly, like since tissues are available for tumor genotyping, yes, like please to be go ahead. If it is, sequentially to add on the liquid is a thing what we are doing, but complementary approach is better than sequential approach. Only plasma alone approach is like not suggested. Our tissue alone approach right now what we are following may not be right. The complementary approach is a better way. Next slide. Next slide. Next slide. So advantage and disadvantage already we discussed, like why tissue versus liquid. It's always accessible, easily, just blood sample drawn, tumor heterogeneity, all these things. Next slide. Recommendations of clinical practice guidelines. Next slide. ESMO guidelines endorse liquid biopsy as a complement or alternative to tissue biopsy for genotyping in treatment naive and resistant cases. I'm not going to do the entire slide, but we have to complement with this with the solid biopsy. Next slide. Even the NCCN endorses the circulated tumor DNA analysis as a complement, sometimes like than sequential, always additional approach or complementary approach is a better way. With this, I conclude the session and thank Rachana ma'am once again.
Thank you, Dr. Kripa. You have discussed the pros and cons of liquid and tissue biopsy, and you have given us valuable insights into why complementary testing is the way forward to identify most of the mutations in lung cancer. So now moving on to the therapy part, I would like to invite Dr. Rekha Bansal. a consultant oncologist from Apollo Hospitals, Hyderabad, to discuss on the most common targetable mutation in lung cancer, the EGFR. Over to you, Dr. Rekha.
Hi, thank you, Dr. Rachana, and thank you, AstraZeneca, for this opportunity. I'm trying to share my screen. So, yeah, I think I did here. You guys can see it now, right? Yeah. So, very quickly, we all know in metastatic EGFR NSCLC, Osimertinib is the undefeated winner, and we all know now it is the standard of care. Of course, a lot is happening. Let's just walk through the slides very quickly. I will skip this part because Dr. Deepthi has already discussed this in detail. In metastatic NSCLC, most of the biomarkers have been identified. More than 50% of the patients have these biomarkers. Now we are all testing them by NGS. So when it comes to the EGFR mutation, we are not talking just about one mutation. It is a spectrum of mutation spanning across the exon 18 to exon 21. And the prevalence of this mutation is found to increase when we move from stage 1 to stage 4. Now, that is why we are even testing in early stages, and we are able to offer adjuvant treatment to these patients. So we know how this EGFR mutation works. It basically causes a constant downward activation, and even without the ligand binding, there is a constant activation and signaling leading to proliferation. So the current treatment options for advanced NSCLC, this is fast evolving. Of course, whenever we have a mutation identified, we try to give the particular target. So Osimertinib works across all the EGFR mutations. Earlier, we were when first and second generation were being used, we would wait for, we would try to identify T790M mutation as a resistant mechanism and then use Osimertinib. But of course, now we are using it. That happened. Osimertinib is standard of care because of the FLORA trial data. We are all pretty well aware with the FLORA trial data. So this studied in the use of Osimertinib versus first generation TKI in treatment naive metastatic NSCLC. They included CNS metastasis patients who were stable, and crossover was allowed. And despite the crossover being allowed, we saw a benefit. So only thing I would want to highlight here is we are all very well aware of all this data. Only thing I would want to tell here is about 60% of the patients were exon 19 deletion and about 40% patients were L858R. Yes, it did show PFS benefit, which was statistically significant with a hazard ratio of 0.46. Everyone benefited. A PFS benefit was seen across the subgroups. Overall response rate was improved slightly, but not statistically. But duration of response was statistically better when compared to the first generation TKI. All of this led to improvement in the OS, which was statistically significant. Now, Osimertinib is a very easy to use drug, hardly any grade 3-4 toxicities. So here only thing so basically hardly any grade 3-4 toxicity. It's a very tolerable drug. So FLORA, based on the FLORA data, we know there is statistically significant and clinically meaningful improvement in PFS. Over the Osimertinib is now the standard of care. It also led to improvement in the CNS PFS, and final OS data showed a promising survival trend favoring Osimertinib. Comparable safety profile of Osimertinib to standard of care. Now, let us talk about a little bit about the CNS efficacy. So it has been found that when compared to the wild type EGFR metastatic NSCLC, patients with mutation in EGFR are prone to have more brain metastasis. It could be leptomeningeal or brain parenchymal metastasis. So even in those patients with or without the CNS metastasis, the PFS benefit was seen, which was statistically significant. Now, what I tried to highlight was L858R, so Osimertinib versus Decometinib. We all know that, the quantum of benefit was not so much in L858R. So do we opt for Decometinib in this set of patients? So only problem is the Archer data. The Archer data also, so it did not meet its primary endpoint, the Archer, because they were supposed to test the data hierarchically. and it had not met one of the overall response rate was not met. So even though there is OS benefit, we cannot take this into account, given the fact that all this was predetermined and it unfortunately did not meet the preset overall response rate, was not statistically significant. So even though numerically we might say that OS was improved, but we need to take this with a pinch of salt, because it was not pre-decided. So p-value could not be given to the OS in Archer 1050. Now, what about afatinib? I think this is again proven without doubt that osimertinib is better than afatinib. For the want of time, I'm just skipping this because we are all well aware of all this data. So how do we sequence? Should we use a first generation TKI, then on the development of T790M, should we use osimertinib? But by doing that, there is a lot at stake. First of all, we don't know how many, only 60% of the patients develop T790M mutation, and most of the patients do not actually receive the second line of therapy. So it is best that we hit it hard the first time around. We should give them the benefit of a drug like osimertinib in the beginning itself, rather than reserving it for a later line of therapy, because most of the patients do not even go on to receive a second line of therapy. And like I said, most of the patients may not even develop this T790M mutation. So according to the guidelines, osimertinib is the preferred first line recommendation in a metastatic NSCLC whenever an EGFR mutation is found. Now, of course, I think no more, it's not the discussion of whether osimertinib or not. I think the discussion is whether osimertinib alone or in combination with chemotherapy. So the FLAURA2 data is very promising. Of course, combining with chemotherapy comes at a cost of toxicity. So the FLAURA2 data randomized treatment-naive metastatic NSCLC patients with stable CNS metastasis to either receive osimertinib in combination with pemetrexed and carboplatin, or osimertinib alone. And the baseline characteristics were well matched between the two arms. There has been a PFS benefit has been observed, which is statistically significant, and hazard ratio is only 0.62. Even the blind independent central review has also confirmed the PFS benefit. And the benefit has been observed across all the subgroups. This is pending the OS data. So at this point of time, okay, let's talk about the toxicity. Yes, there is increased toxicity, but I would, at this point of time, I would probably say nothing that we cannot manage. Yes, there would be more myelosuppression, but then I think we are all well versed. It's about identifying the right patient who would benefit from this combination, probably younger patients with higher disease burden, because the CNS PFS is also very impressive with this combination. Right now, this is not the standard of care. We'll have to wait for the OS data to come and identify. Actually, I think TP53 mutation has been found to give better results when osimertinib is combined with chemotherapy. So until the data comes, we'll have to wait. Let's talk about the Mariposa study. Again, this is looked at combination of amivantamab, which is a bispecific anti-EGFR antibody, with lesertinib, which is also a third generation TKI. This combination was compared with osimertinib alone and with lesertinib alone. And so far, again, there is some meaningful clinical activity. There is PFS benefit which has been observed. There is overall response rate and duration of response benefit also seen with this combination. Only the OS data is immature. The interim OS benefit, it shows a trend. I mean, HR of 0.8 is, I know we cannot accept this at this point of time, but hopefully this will get better with time. Or let's see, I don't know whether this will get better with time or not. The combination obviously has more grade 3 AEs when compared to osimertinib alone. So to conclude, for the first time in the evolution of the EGFR TKIs, osimertinib translated PFS to a statistically significant OS benefit. A median PFS of 18.9 months and OS of 38.6 months was seen with the osimertinib. It also is effective in patients with CNS metastasis. And of course, the side effects are barely any, and they are definitely manageable. Thank you.
Thank you, Dr. Rekha, for taking us through the inhibitors, the Osimertinib, and also through the Mariposa trial. And yes, we have very good targetable agents now, and we are expecting more results to come out from these trials, for the trials also. So, and next, moving on to the panel discussion, I would like to invite the panelists for today to discuss a case scenario which we commonly come across in our clinics, most frequently seen case scenarios of EGFR mutated NSCLCs. So for the panel discussion today, I would like to request Dr. Rekha, Dr. Kripa, and Dr. Lakshmi Deepthi, our speakers, to join up. Along with them, I would like to invite Dr. Sumant, consultant medical oncologist from KF Hospitals, Hyderabad, Dr. Rajni Priya, senior medical oncologist from Mahatma Gandhi Cancer Institute by Visakhapatnam, Dr. Sharat Chandra, and Dr. Naresh, consultant oncologist from Hyderabad again. So I guess all the panelists are there in the meeting.
Yes, ma'am.
Yeah, okay. I'll try to share my screen. Is my screen visible?
Yes, ma'am.
Yeah. Okay. So moving ahead with the case discussion, this is a case of a 64-year-old gentleman who presented with cough and progressive breathlessness and severe backache in October 2020. He could not walk without support for the past 10 days, and he has a complaints of giddiness and weight loss of 5 kgs in past 1 month. He's a non-smoker. So on evaluation, he underwent a PET CT scan, which showed a mass in the right upper lobe of the lung with hilar nodes and multiple bone metastasis. And a biopsy was done for the lung mass, and on histopathology, if a biopsy was done for the lung mass and the histopathology is showing a poorly differentiated carcinoma, what are the IHC markers we request? Yeah, so for this, I would like to ask Dr. Lakshmi Deepthi to comment on what are the IHC markers you generally expect from your pathologist for a poorly differentiated carcinoma of the lung.
The markers which we usually expect are the P63, napsin, PTF1.
Yes, as asking for the IHCs to differentiate between the adenocarcinoma, squamous cell carcinoma, and the small cell carcinoma. So for this patient, the TTF1 and napsin were positive, and it was negative for P40, giving us a diagnosis of adenocarcinoma. And for the molecular analysis was also done. So I would like to ask Dr. So, what the marker the mass for adenocarcinoma? Dr. Suman?
Madam, please repeat the question. Your voice was not clear. And please repeat the question.
Oh, sorry. Yeah, I was asking what were the molecular markers you sent for an adenocarcinoma of the lung? What are the molecular markers you're requesting?
Usually we go for a TTF1 initially. If it, if it is negative to confirm it, we can go for napsin also. Most of the 90% of the tumors of adenocarcinoma would be positive for TTF1, and only 10% of them would be negative of the for the TTF1. If it's still negative, we can go for a more specific marker, that is napsin. Then we can confirm for this adenocarcinoma.
Yeah, once a diagnosis of adenocarcinoma is made, what are the other molecular analysis you're requesting for? Are you doing a sequential testing, or you're doing a multi-gene testing, and what are the genes you're asking?
Ma'am, usually at my practice, I usually go for a limited NGS panel, and also I see for PDL1. So all the targetable mutations, around 12 genes that I would include in my limited NGS panel. And also I would like to include that RNA fusion panel also to look for the fusion genes too.
Okay. Dr. Kripa, any difference in opinion or similar in the practice? Dr. Kripa?
Ma'am, Dr. Kripa has left the meeting.
Okay, okay. So, Dr. Rekha, can you please take this question? Any difference in your practice of the molecular analysis of an adenocarcinoma lung?
No. At this point of time, I'm also doing the limited NGS based on the coupon, basically 12 gene panel. Most of the companies are offering, so that is what I'm doing.
So, what would be the further evaluation for this patient who has a diagnosis of adenocarcinoma with EGFR exon 19 mutation? Rest of the markers being negative and PDL1 was also negative. So, what would be the further investigations you would like to do, or you want to start the treatment directly? I would ask Dr.
Hello? Hello? Am I audible,
Hello.
ma'am?
Yes, Dr. Rajni, please. Yes,
Yes,
Rajni,
ma'am.
you can go ahead.
So we'll go with the staging workup, PET CT scan, and MRI brain, ma'am. MRI brain.
So you're doing MRI brain for all your EGFR mutated NSCLCs or all NSCLCs as such, the metastatic disease?
Not for all NSCLCs, especially for those with driver mutations, EGFR-ALK, who have more propensity for brain metastasis. Maybe I'm pushing them for MRI brain.
Okay. Dr. Naresh?
Can
you please take the same question?
Yes, ma'am. I'm doing in all patients, ma'am, in stage 4 NSCLC. As we have seen, about 15-20% they have asymptomatic brain mets. So I do in every patient of NSCLC, ma'am, with stage 4.
Are you addressing the asymptomatic brain mets extra therapy other than the plan?
Ma'am, if there are asymptomatic brain mets, I would target with the depending on the mutation status, ma'am. Like for EGFR, I will go with Osimertinib in first line. Otherwise, we're not treating with RT, ma'am. The patient is asymptomatic.
With bone and brain. So, this would be your plan of
Ma'am, I'm
management for
sorry
this
to
patient with a
interrupt.
bone and brain.
Ma'am, your voice is not
Yeah, please.
clear, ma'am.
Should I repeat the question?
Yes, ma'am. That last
Is it better now?
2 to 3 sentences were not clear, ma'am.
Yes,
Actually,
ma'am.
that was an interruption.
Okay. Dr. Suman, this was for you only, actually. The stage 4 NSCLC adenocarcinoma with exon 19 deletion with brain and bone mets.
Ma'am, actually, ideally, the patient has both bone and brain mets. I would look for how bad are there, whether there is a acute spinal cord compression or there is a impending fracture of bone lesions, and how bad were the brain metastasis, where the patient is symptomatic of the brain mets. So actually, for the NGS panel to get the time that would take would be around 7 to 10 days. So I would like to discuss with the patient regarding the awaiting the results of this NGS panel. If the patient is symptomatic, and I would like to start with steroids and would like to wait also, but keeping in view that the patient may land up in more trouble for these 7 to 10 days, we need to discuss about giving a whole brain RT in the initial phase of the therapy in the first 7 to 10 days, especially if the patient is symptomatic. And if the patient is not symptomatic and the disease burden is not that much high, we can wait for the NGS panel to come up, and we can start off the therapy later on also. And also, ma'am, according to the case, the patient is unable to walk. It was written as, were there any significant cord compression features also? Okay.
No, that was more of pain only.
Okay. Then we can manage with analgesics, and we can add a zoledronic acid also. And we can still wait for this NGS panel, as the brain mets were stable, I think, in this case.
Yeah, the patient is not symptomatic for the brain mets.
Yes, yes. Okay, okay.
But
Then
there
we could...
are multiple lesions involving the cerebellum also, and the NGS has shown an exon 19 deletion.
Okay, then we can start on steroids, and we can start off with tablet Osimertinib upfront.
Okay. Any role of whole brain RT or?
To be frank, the role of whole brain RT usually, if the patient is symptomatic and if it is not resolving with the steroids, then we can go for whole brain RT, keeping in view the CNS activity, high CNS activity of these agents, especially Osimertinib. And if the patient had been all positive, we can still wait in that situation also for the Lorlatinib or whatever the drugs that have got high CNS penetration capability. So in this era, we can still wait to watch for how the patient responds with our EGFR TKIs.
Okay. Dr. Naresh, your plan of management for this same patient?
Ma'am, so seeing the MRI, I think he's having multiple multifocal brain mets, and he's having a cerebellar mets also. So I would, even though patient is asymptomatic, I would like to add WBRT, whole brain RT, because the time to response of those drugs might take few weeks to act. So there can be impending CNS effects. So I would prefer WBRT in this case, ma'am.
Okay. Dr. Deepthi, anything in your plan management?
No, ma'am. I would, as the patient is asymptomatic for the brain mets and the bone mets, I would start with Osimertinib and Zoledronic acid.
Okay. So for this patient, we thought of giving radiation, palliative radiation to the skeletal metastasis, which were painful. Also suggested whole brain RT give you the site of brain lesions, especially involved cerebellum, and also plan for EGFR targeted therapies and bone modifying agents. So these are all the first generation and the second and third generation TKIs which were studied in the EGFR mutated NSCLC. And we can see the progression-free survival rate was significantly better for Osimertinib. These are all cross-trial comparisons and among all the different TKIs for EGFR. And what is the degree of penetration of Osimertinib into the CNS? In the mouse models, higher brain concentrations were seen with the usage of Osimertinib compared to other TKIs, that is the Gefitinib and Afatinib. And the brain concentration was significantly higher with Osimertinib. And these are the mapping of the brain after the Osimertinib dosages. And we can see that the penetration is very good for the Osimertinib. And we can see the different PET CTs done for patient 1 and patient 2. The parametric imaging, we can see as the duration increases, the day 22, there is a significant penetration into the brain by the Osimertinib. So this is a flow chart for the management of EGFR mutated NSCLC and patient with CNS metastasis. Brain metastasis, symptomatic, we can consider for local therapy such as surgery or SRS if they are limited brain lesions. And if not symptomatic, we can consider for Osimertinib. Or patient who has received a first generation TKI on progression, if there is a CNS progression and CNS or systemic progression, we have to first check whether there is a systemic progression also. Only CNS progressive disease, check for T790M and plan for Osimertinib. If T790M is negative, plan for SRS or whole brain RT. And similar with the systemic progression also, we have to check for the T790M mutations. And if positive, we have to start with Osimertinib preferably. And this is the FLORA data, which Dr. Rekha has already presented. This is the CNS part of the FLORA trial, where Osimertinib has demonstrated a superior systemic PFS benefit regardless of the CNS disease status. Hazard ratios of 0.4 in patients with a known and or treated CNS metastasis, and a similar hazard ratios in patients without a CNS metastasis also. So these are the comparisons of the Osimertinib, Dacomatinib, and Afatinib trials in the first line of EGFR mutated NSCLCs. We can see that a FLORA trial is the only trial which has included patients with the baseline asymptomatic CNS metastasis, whereas those patients with CNS metastasis were excluded from the Archer trial of Dacomatinib. And also we can see the median CNS progression was significantly better with the usage of Osimertinib in the FLORA trial, 15 months versus 9.6 months with a hazard ratio of 0.4. And this is again a comparison of the first generation TKIs and the Osimertinib for the brain metastasis. We can see the overall response rates is better and the disease control rate is also significantly better with the usage of Osimertinib. So this patient has been started on Osimertinib 80 milligrams per day and palliative radiotherapy to the spine for backache and zoledronic acid also. But this patient has denied taking brain RT, started on steroids for a few days and then tapered gradually. And the patient wanted to wait on whole brain RT. And follow PET CT if you see, the right upper lobe lesion has decreased in size. There is a reduction in the right hilar and paratracheal nodes. And MRI brain is also showing a significant decrease in the brain ring enhancing lesions. This is for a patient without whole brain RT and only on Osimertinib. And further evaluation in July 2021, there is a complete resolution of the brain metastasis on the MRI brain without requiring any additional interventions. So similar to this case, we do have the old patient was diagnosed on being on chemotherapy for stage 3A, developed CNS metastasis, and the patient started on Osimertinib. Similar metastasis, patient complained ataxia, which worsened significantly. And this patient was also given Osimertinib without radiation, and the response was very good. And we have another case report of complete remission in multiple brain metastasis for patient treated with first-line Osimertinib. And another study was also there which demonstrated significant efficacy of Osimertinib in CNS metastasis. The median progression-free survival for these patients was 11.8 months. So this study has concluded that Osimertinib demonstrated high efficacy in brain metastasis, and all trial arms have displayed a significant decrease in the number and diameter of the large lesions. Sorry, suddenly lost the connection.
Ma'am, your sides are not visible.
Yeah, suddenly lost the connection. Now is it visible?
No, ma'am.
Not yet?
No, ma'am.
Started sharing the screen, but
Yes, ma'am. Now visible.
Now it's visible?
Yes,
Yeah.
ma'am.
So the further follow-up PET CT for this patient has luckily showed a complete response. But what if there was not a complete response? What if there was a progressive disease in that PET CT? What would be your treatment plan if there is a systemic progression for the same patient who has received Osimertinib alone without any whole brain RT? Dr. Deepthi, if you can take this question. 2 years of Osimertinib, progressive disease.
Then I would like to see the locate sites of progression of disease, madam. And if the biopsy is feasible, I would like to go for a repeat biopsy of the lesion to see for any change in the histology and also to see the marker status.
Okay. Dr. Rajni Priya?
Yes, ma'am.
If there is a systemic progression, not an oligo progression, I would say it was a full-blown progression with multiple lesions in the liver and adrenal. So what would be your treatment plan?
Would go for liquid biopsy, madam, rather than biopsy. In later lines, usually we go for liquid biopsy because the patient PS will come down and patient may not be willing for a repeat biopsy and all. So we look for any other new targetable mutations.
So what are the targetable mutations you are expecting on progression of EGFR-TK?
Usually we had seen some patients, ma'am, like post Osimertinib, we have new mutations, like they have developed co-mutations like ALK. So we had treated them with Osimertinib and we even added Alectinib. So very rarely it happens, but we should not miss and we do get. So in later lines on progression with Osimertinib, we have options like Amivantamab, which is coming up post Osimertinib progression if the patient is affordable. So along with chemotherapy, we can give Amivantamab or just chemotherapy.
Okay. Would you miss out on anything if you're not doing a tissue biopsy?
Dr. Rachana, one of the mechanisms of resistance is MET amplification, so MET mutation. So maybe we should look for that.
Yes, doctor. So
Yes.
either of you, anything you're missing out if you're not doing tissue biopsy?
Histology
Either
transformation.
Dr.
I would like to do tissue biopsy.
Yes, histological
Only the
transformation.
histological transformation is the only thing for which
Small
tissue
cell,
biopsy helps.
yeah.
That's
Yeah.
all.
It's
But that is
it's a
very
rare
rare.
case
So
scenario. Yeah, it's
yeah,
a
that's
rare case
yes.
scenario. Yes. So if there is no other mutation, still EGFR exon 19 is still persistent. What would be your treatment options? Dr. Naresh?
Ma'am, I would like to go for chemotherapy, ma'am. Plus, we have recent approval for maybe the patient is available. I would like to add antibody plus chemotherapy.
Okay. Dr. Suman, what would you like to do?
Ma'am, actually, I have not yet used this amivantamab plus chemotherapy based on this Mariposa 2 trial, but even then, the patient, we have to look after the general condition of the patient also too, because the amivantamab plus chemotherapy arm has very high incidence of these grade 3 events, along with some infusion-related reactions. We have to have some experience with managing these two. But in clinic, there is no transformation and the still exon mutation is positive. I would like to give chemotherapy along with ATI and BEV combination too. That's one of the regimen, but that too doesn't have a very strong, data. It's only a subset analysis of that IM power 150 trial. Apart from that, if the patient is not affordable, I will go only with doublet chemotherapy in the second line. If there is no any actionable mutation, if there is only any other mutation was not found, I will go with the doublet chemotherapy as another option.
Okay. As Dr. Suman got a good point, actually, I would like to ask if anyone has an experience with amivantamab plus chemotherapy or amivantamab alone.
I didn't get you. Yes, ma'am. One of my colleague, Dr. Deepak, has given amivantamab in our ward, for the patient who has progressed post Osimertinib, but that amivantamab was not given with chemotherapy. Given the looking after the general condition of the patient, as the patient may not be tolerable for the doublet chemotherapy. So single agent amivantamab was given, and the patient had reactions in the first 2 weeks of therapy, and then patient progressed after 3 months of the amivantamab therapy, and later on succumbed to death. So that was the one case that I had experienced in my practice.
Okay. Dr. Rekha, any experience of increasing the dose of osimertinib on progression to 160 mg?
No, I've never done that. So in exon 20 insertion earlier, before other drugs were available, we were trying to give that, but I've never actually done that for any other patient. Yeah.
Okay. So with this, I would like to conclude the panel discussion by saying that radiotherapy may not be mandatory for most of our patients who are asymptomatic for brain metastasis with the advent of new drugs such as osimertinib in the EGFR mutation NSCLC or lorlatinib and alectinib in the ALK positive NSCLCs. It's a traditional teaching that patients with the brain metastasis in critical areas such as cerebellum would require a whole brain RT or an SRS if feasible. But with these new drugs, maybe we can avoid the toxicity of whole brain RT, though it would be skeptical for us to choose when the patient is very symptomatic at presentation, then we have to go with radiation therapy. So if any biomarkers which can predict an excellent response to TKS, any of the panelists can please take this question. Dr. Sumant or Dr. Naresh, any biomarkers to predict an excellent response? This is the last question for the panel discussion for today.
As such, ma'am, only exon 19, it works well compared to exon 21, but markers I'm not aware, ma'am.
Actually, ma'am, in the recent update of this FARA trial, the L858R has failed to show an overall survival benefit, where in exon 19 deletion, the subset analysis has found a good profound benefit with osimertinib. But it had a progression-free survival benefit in both the mutations. There is just a subset analysis of L858R. So exon 19 actually clearly gives a clue that, gives an indication that osimertinib fares very good in that subset of the population if you take both the mutations.
Okay, and thank you all the panelists for a wonderful discussion on CNS metastasis involving the EGFR positive NSCLC. And yeah, we'll continue with the rest of the session. So moving on to our next talk, this is selecting. Sorry. So I would like to invite Dr. Naresh, medical oncologist from Cancer Clinics, Hyderabad, to discuss on the less common driver mutations in advanced NSCLC, the MET, RET, ALK, ROS, and NTRK. Dr. Naresh, over to you.
Okay, ma'am. I'll share the screen, ma'am. I'm unable to. Ma'am, the screen visible, ma'am?
No, Naresh, we can't see your screen.
I think from that end, I think we have to. Now is it visible, ma'am?
Yes,
No,
yes,
sir, it
Naresh.
is not visible. We have played your slides. You can
Okay.
just say next whenever you want to move to the next slide.
1 second. Actually, the slides are different. Can I share the slides?
Sure, sir, you can do that, sir.
Now is it visible?
Yes, Naresh, we can see your slides now.
Okay. So I'll be, my topic is on selecting therapy for less common driver mutations for advanced lung cancer. So thank you for AstraZeneca for giving this opportunity. So as we know, we have moved from histology-based treatment to molecular-based treatment. And in adenocarcinoma, we see the most common mutations like EGFR, ALK, KRAS is in 25%. And other mutations like MET, ROS, BRAF, there are around 2 to 3%, and less than 1% in NTRK. So these are Western data, but when coming to Asian data, we have more of EGFR mutations, constituting about 40% here. And we do a broad-based NGS panel I discussed earlier. So these are different tests we do. So coming to optimal therapeutic regimens for ALK positive NSCLC. So as we know, it's a EML4 ALK rearrangement. We have different variants V1, V2, V3, and V5. So in ALK positive NSCLC, we have seen the life expectancy has improved almost to 7 years with the advent of new ALK TKS with the sequencing of these TKS. So coming to the overview of these different drugs, we have 3 generations of drugs. First one is Crizotinib, which is the first drug. The PFS was around 10 months when compared to chemotherapy. And other second generation like Alectinib, it was around 34 months compared to Crizotinib with a hazard ratio of 0.4. Similarly with Ceritinib and Brigatinib. And we have a third generation TKI with PFS was not reached with the 3-year update. It was around 0.27 hazard ratio. And there was significant worse benefit with Alectinib. Lorlatinib, the data is awaited. And the response rate, you could see it was similar like 70, 75. Coming to CNS, as CNS is the most important part in ALK NSCLC, the rates are higher with Alectinib around 80% and with Lorlatinib at 83%. And the mutations, you can see the ALK resistant mutations, they increase as a number of generation of TKs increase. So this is the intercalary activity of Alectinib. You could see the time to progression was significantly low compared to Crizotinib. both in brain mets positive with hazard ratio of 0.18 and with 0.14 in brain mets negative patients. This is with lorlatinib. The response rate was around 83 with a CR around 72%, with significant reduction in intracranial progression with hazard ratio of 0.1 in brain mets positive patients and 0.02 in brain mets negative patients. Coming to safety profile, so with alectinib we had like transaminitis was a common. In bigatinib it was diarrhea and transaminitis was seen. When coming to lorlatinib, it was a metabolic lipid profile was deranged with cognitive dysfunction, visual disorder, and mood effects. And the grade 3 for more than grade 3 were higher with the brigatinib and lorlatinib compared to the alectinib. So coming to resistance mechanisms, we have three types like on-target, off-target mechanisms. On-target, the most common is the G1202 mutation, which can be targeted through a third generation lorlatinib. But we tend to have also compound mutations, which even lorlatinib cannot target it. So we have fourth generation TKS. Other off-target, we have bypass pathways with downstream pathways activation and the lineage transformation. So, sequencing of this TKS, you could see the lorlatinib response rates or PFS and OS, they decrease with the number of generations used. And in ALK positive mutation, there was a better benefit with lorlatinib compared to ALK negative mutation. And use of brigatinib post-alectinib showed a modest response rate around 17% with PFS of 4.4 months. So these are upcoming fourth generation ALK. We have these two drugs, so which have activity even in compound mutations, which are which doesn't activate by lorlatinib. And also we have a sparing TRKB effect with these newer drugs. So coming to ROS1 NSCLC. So we have first approval with crizotinib showing responses around 72% with a median PFS of 19 months. In second drug is entrectinib with the response rate around 68% with a PFS of around 15 months. And the most side effects are grade 1 and grade 2 with dysphagia, dizziness, and weight increase. And the CNS activity, it's almost 80% intracranial oral response rate with entrectinib, with the intracranial PFS around 8.4 months. We have a third drug, repotrectinib. It was approved recently. So with both in first line and second line it was seen. First line the rates were around 78.9% with a PFS around 35 months, more than double compared to other TKS in this subset. And in second line also it was around 38% response rate with a PFS of around 9 months. And with a significant intracranial response of 89% in first line compared to 38% in the second line. And the side effects are tolerable, and most of them are in grade 1 and 2. So coming to the resistance mechanisms, we have the most common it's ROS1 G2023 resistance mechanisms. So this can be targeted by these three drugs. And the new drug, it's under trials, NVL 520. So it has shown to benefit both in prior entrectinib, repotrectinib, and also chemotherapy. Coming to red positive NSCLC. So there have been many TKs have shown activity, but for modest response rates, we have cabozantinib with 28% response rate, vantinib around 18%, lemetinib around 16%, with a PFS around 6 to 7 months. Now we have a selective red positive inhibitor, selpercatinib, approved recently. So it was showing a response around 84% overall response rate with a median PFS around 22 months, with significant intracranial response rate of around 85%, with 19.4 months of intracranial PFS. And the side effects profile were like diarrhea, fatigue, similar to other TKS with transaminitis, and most of them were 1 and 2. So this is a phase 3 trial. In this trial, they took the 3B3C non-squamous NSCLC with treatment naive, red fusion identified, they are randomized in 2:1 to selpercatinib versus chemotherapy plus or minus pembrolizumab, and there's optional crossovers allowed. So you can see the intent to treat population pembrolizumab group. With this drug, the PFS was almost double, 24 months, with a standard arm of 11.2 months, with a significant hazard ratio of 0.46. And intent to treat population also had a significant benefit. Other drug, we have pralsetinib, with overall response rate of around 72%, with a median PFS around 13%. So in this TKI, there was like neutropenia, leukopenia, anemia, unlike other TKIs, with transaminities, other pneumonitis were there. So what is the role of retesting in red positive? So we have newer drugs which can target these mutations in red positive NSCLC. Coming to NTRK positive NSCLC, we have drugs like larotrectinib, which was approved in 2018, with a significant overall response rates around 74%. In TRK positive lung cancer, with a median PFS around 33 months. And intracranial efficacy also was around 70% with this drug. And the side effect profile were like transaminitis, weight gain, diarrhea. Second drug is entrectinib. So it is showing a response of around 64% with a median PFS of around 20 months, and with intracranial response rate around 60%. So role of retesting, we have both on-target and off-target resistance mechanisms. On target, we have second generation drugs like repotrectinib and selpercatinib in this TRK group of drugs. So it has shown a response rate of around 43% with NTRK positive NSCLC, and in solid informed mutation around 60% was the response rate with median PFS of around 7.4 months. Coming to MET positive NSCLC, so we have these drugs like crizotinib showing a response around 30% with median PFS of 7 months. Tepotinib in Vision 2 trial around 40% response with a PFS around 8.5 months. Capmatinib around 40% with previously treated patients. Treatment around 60% with a PFS around 5.4 months. So it's a new drug savolitinib. The phase 2 trial was done. So it has shown a response around 47% in this trial. And there was update of OS and PFS. The PFS was around 6.9 months in the overall population. It also had a pulmonary sarcoid component, carcinoma, which was a high-grade tumor. The PFS was low in this subset. When the OS was around 10 months, whereas in this primary pulmonary sarcomatid cancer, it was around 10 months. So these were overall the drugs which are discussed. So, and these are recommendations. So to conclude, we have widely availability of NGS testing, so which lead to detection of these rare mutations. And liquid biopsy, it complements the NGS testing. In case if you miss any mutations, it will be complementary, or in case of any tissue is not available, it helps in detection of mutations. ALK inhibitors, so we have a number of drugs, and the selection depends on the efficacy, side effects, and the cost. So we have other TKs in our setting. Cost is a major issue, and generics are available only for EGFR drugs, and even like insurance, they are not covered in insurance. So paying from out of pocket would be a major issue in our population. And in some subset, chemo plus IO could be an option, like in MET, NTRK, or BRAF. And participating in trials would be a good option in our setting. Thank you.
Thank you, Dr. Naresh, for taking us through all the mutations in NSCLC and the drugs which are approved and the drugs under trials and the data from different clinical trials. So moving on with the same discussion of MET exon 14 skipping NSCLC patients, I would like to invite Dr. Sharat Chandra, consultant medical oncologist from Hyderabad, to discuss about the MET exon 14 mutation.
Yeah, good evening, everybody. Thank you, Mark and Dr. Rachana, for giving me this opportunity. Can I also share my screen so that it will be easy for me to skip through the slides?
Yes, yes, please.
Yeah. So is the screen visible? The screen
We
is
can
visible.
see your screen, Doctor. Yes.
Yeah, okay. So this is the last topic for today. I think I'll rush through because the topic is vision for metaxon 14 skipping in NSCLC patients. So to highlight the importance of testing and then to drive through the insights in the management of these patients and also the treatment guidelines would be the overview. So just to go into the disease burden of lung cancer, globally, we know lung cancer accounts for 14% of all cancer cases in males and 8% in females. In India, it is about 8% of all cancer cases in males and 3% in females. So we know that metaxon accounts for 3 to 4% of all our driver mutations. So we all know molecular testing is of paramount importance. I think we've been doing this for the last 3 to 4 years. So way back in 2022 only, almost a broad biomarker testing was suggested across different subtypes, even in squamous. We now go ahead and check for a broad mutation panel. So what is more important in metaxon skipping mutations is I think by now everybody does the NGS on tissue, but then a little more advantage for a metaxon skipping mutation diagnosis is through a liquid biopsy. So definitely tissue is still the gold standard, but then in liquid, when the tissue is not possible or suitable due to different factors, liquid biopsy is a viable alternative for checking metaxon skipping mutations. So as we can see, the different factors which are comparable between the tissue and liquid. So this is the initial data which came out way back in 2019, where they had just done a retrospective analysis of all the available response rates or the PFS, and then went on to check the OS between the patients who underwent chemotherapy versus who received a metaxon skipping MET inhibitor. It could be any of the available MET inhibitors back then. It favored MET inhibitors to the tune of 24.6 months when compared to 8.1 months in terms of OS. So with the hazard ratios of 0.11. But this was the initial retrospective data from where the prospective trials had actually started way back in 2018 and 2019. So the available guidelines between NCCN and ESMO, we now treat metaxon skipping mutation patients with either of the two available TKS, which could be tepotinib and capmatinib, and in certain circumstances, we also use crizotinib if we don't have the available two TKS. That is from the NCCN, and also ESMO also supports the same. Tepotinib and capmatinib are the first line drugs, and then you could also go ahead and use crizotinib if you have metaxon skipping mutation. So the point of discussion today is tepotinib, and the data which came out in a prospective fashion for the first time is through VISION study. This is one of the largest study involving more than 300 patients with metaxon skipping lung cancer patients. It's the first clinical trial of metaxon MET inhibitor to prospectively enroll patients based on both tissue and also liquid biopsy. One important factor to note is more elderly patients were included, median age of more than 70, and then it is line agnostic. So both treatment naive and previously treated patients and also patients' brain mets were all included. So the quick design. It is a phase 2 trial where metaxon skipping mutation was detected either by liquid or tumor, and then there was only one cohort which had tepmetco at a dose of 450 mg once daily. They could include both treatment naive and previously treated. These were the two cohorts which were available. So the primary endpoint was overall response rates, with the secondary endpoints being duration of response, PFS, OS, and then safety. So almost 164 patients of treatment naive NSCLC and also 149 previously treated who could have received chemotherapy were included, and then brain mets of around 17% in treatment naive and 20%, around 20% in previously treated patients were all there in this particular study. So going into the separate features, almost 53% of patients were more than 75 in the tissue positive mutation category, and also in liquid mutation detected category, almost 42% patients were more than 75. So this is one peculiar feature of this particular study. Usually more than 70 patients are included in all our trials, which we generally see. So 36% were detected through liquid only, 42% through tissue only, and then around 21% were detected by both. So the results, the overall response rates in terms of treatment naive patients who were enrolled via tissue biopsy, the overall response rates were around 59%, duration of response around 27 months, with a PFS of 16, translating into an OS of around 30 months, with a beautiful waterfall plot, which we could see almost 90% patients experience tumor shrinkage with this particular drug. These were the treatment naive patients enrolled via tissue biopsy. Coming to the previously treated patients, an impressive 50% overall response rates, duration of response almost 10 months, PFS of 11.5 months, and an OS translating to almost 20.4 months. So they were consistently sensitive to tepotinib, even in the patients who were previously treated with chemotherapies. So coming to the data in treatment naive Asian and also previously treated Asian patients, around 50 patients were there in both the lines, treatment naive and previously treated. Overall response rates were again impressive, with around 64% and 50% in both the lines, first line and second line. OS of around 32.7 months in treatment naive and around 23.7 months in the previously treated versions. So what is the response rates in patients with brain mets? Around 17% and 20% were the number of patients which were there in the two stratas. So at baseline, around 18%, yes. So the intracranial disease control rates were around 88.4%, very impressive there. Intracranial responses of 66.7%. If you consider only the intracranial PFS, it was around 21 months. Again, very impressive in lines of ALK mutated lung cancer response rates. So intracranial duration of response is not even reached. This is one particular patient who had a beautiful complete response rate going on into almost 6 months there. So that is just shown here. The MRIs are nicely shown here. So then if you just compare the two available drugs for us, which are tepotinib and capmatinib, the salient features are just shown here. So 25% brain penetration with tepotinib. Even capmatinib has a good brain penetration to the tune of 9%. So both work in brain mets, but then the response rates are more with tepotinib, with around 86.6% intracranial disease control rate and 71.4% intracranial control. And when compared to capmatinib, around 54% is the intracranial response, which is also impressive. So the dosing, we all know, 450 mg once daily, around 225 mg tablets of 2 tablets are taken with tepotinib. And then capmatinib, it is a little different, 4 tablets per day, maybe 800 mg is the initial dose, and then depending on the dose reduction, we cut down. So efficacy, as were just discussed with tepotinib, when compared to when coming to capmatinib, around 12.5 months is the PFS, 25.5 months is the OS, with the overall response rates impressive at around 68.3%. So not much different, but then those are the two drugs which are available. So then again, traditionally we are asked not to compare, but then if one had done this, then between the two drugs, the PFS is around 22 months with tepotinib, 12.2 months with capmatinib, coming from the geometry study, and OS around 30 months with tepotinib, 20.7 months with capmatinib. So that indirect comparisons confirm the clinical benefit of tepotinib when compared to capmatinib. So these are the numbers which are available. So definitely between the two drugs, convenience of dosing is definitely more with tepotinib, because it is available as a 225 mg tablet. So if one wants to dose reduce, you could just cut down to 1 tablet. of 225 mg from 450 mg. Then with capmatinib, it is a little more, little different. So from 800, you cut down to 600 daily, and then to 400, then to 200. So something like that. So again, in pictorial form, so with capmatinib, the first dose reduction is 300 twice daily, and then the second dose reduction is 200, and then it is permanent discontinuation if you want to cut down lower than that. So again, the key side effects with MET inhibitors, we all know edema is one side effect which we generally encounter more than the other side effects. So 66.5% with tepotinib, around 65% with capmatinib, and also the other drug which is savolitinib, it is around 57.1%. Then the other side effects are not too high, but then nausea, little transaminitis, more with savolitinib, and then fatigue is consistent across the different MET inhibitors. Then edema, we just discussed, it is a class effect of all the MET inhibitors, also one of the most frequently encountered side effect. Then the mechanism generally are not clear, but then what is proposed is it may involve the inhibition of MET in vascular and lymphatic endothelial tissue, and then the capillary leakage is what leads to the edema. How to prevent it? So effective communication and preventive measures are critical to manage this particular edema. At treatment initiation, conservative measures and dose reductions can be used to proactively manage edema. So preventive measures are like limb elevation and exercise, compression, stockings, lymphatic massage, and also sometimes diuretics and regular monitorings. And then management via dose reductions, sometimes permanent discontinuation, grade 4 events, and also what is studied is dose reductions does not generally affect the efficacy of tepotinib. So again, the dose reduction with tepotinib is fairly simple. It is only one dose reduction from 450 to 225. So from 2 tablets to 1 tablet. Using simple conservative measures are effective in supporting patients responding to tepotinib to remain on treatment. So generally dose modifications are uncommon, but then if you encounter a grade 2, grade 3 edema, then you may want to dose reduce from 450 to 225. So why tepotinib? Guidelines recommend it as one of the preferred treatments, NCCN guidelines. Then a vision study is one of the largest in these patients, and first study to enroll patients with both liquid and tissue biopsy in first line, also second line. 90% patients experience tumor shrinkage. 16 months of PFS and 30 months of OS is definitely commendable in this particular subset. Brain mets around 25% brain penetration, leading to a 88% intracranial disease control, definitely desirable. Dosing convenience and safety. So once a day dosing, 450 mg, and then one-step dose reduction. Generally, it is well tolerated. We all saw edema is a class effect. So thank you.
Thank you, Dr. Sharat, for taking us through the MET exon 14 skipping mutations. And with this last talk, I would like to conclude by thanking all my speakers for letting the meeting finish on time, and also for taking us through these wonderful talks of empowering therapy in metastatic NSCLC, the targeted therapies, overview of lung cancer, what the liquid biopsy and tissue biopsy help us in identifying these targeted mutations, and the newer trials, clinical data, and the real-world evidences for these various targetable therapies in lung cancer. If no further questions, I would like to close the session, and thank you once again, the organizers, for giving me this opportunity to conduct this meeting. Thank you.